Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clirnet, serving as the allocated session assistant to ensure a seamless experience. Clirnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clirnet serves as a digital partner for this event hosted by National Medicos or organization. And the focus of today's session is Physiology clinical cases discussion day 3 on cardiovascular system. Now, I would like to invite Sir to proceed. Over to you, Sir. Thank you.
Thank you, Rimpa. Good evening, everyone, and happy Independence Day. On behalf of JSL Medical College Rajahmundry and National Medicos Organization, NMO, I warmly welcome you all to day 3 of our 4-day physiology clinical cases discussion series. Today's session will focus on the cardiovascular system. We are privileged to have as our speaker Dr. Perninkal Srinivas Rao, sir, Professor, Department of Physiology, JSL Medical College, Rajahmundry, and also President Arogya Bharati, Andhra Pradesh. We are also honored by the presence of Dr. Naresh Sir, State Executive Member and IT in charge, NYDC National Youth Day Celebrations, National Medicos Organization, Andhra Pradesh. And also Dr. Sagar Sir, National Organizing Secretary, National Medicos Organization, Andhra Pradesh. And also Dr. S.V. Ramnamurthy Sir, Professor Emeritus, JSL Medical College, Rajahmundry. A heartfelt thank to you, to our digital partner, Team Clirnet, and to Mrs. Ritu, coordinator, and Mrs. Rimpa, moderator, for their excellent support. To begin our session on this auspicious day, we will start with the Dhanvantri Vandana, invoking the blessings of our divine healer for knowledge, wisdom, and good health. Thank you.
नमामि धन्वन्तरिमादिदेवं सुरा सुरैर्वन्दितपादपद्मम् लोके जरावृत्तयमृत्युनाशम् धातारमीशं विविधौषधीनाम्.
Thank you, everyone. Over to you, sir.
Good evening and happy Independence Day. Am I audible?
Yes, sir, you are audible.
Okay, thank you. So, my greetings to Ramanmurthy sir and the members of NMO and dear friends. As you all know, this series has been encouraged by National Medicos Organization, which believes in Swasthya Seva se Rashtra Seva. The country's service is possible by health service by our doctors. Because a healthy country is a strong country. That is the idea of National Medicos Organization. And I thank the organization for giving me this opportunity of reaching to so many of you. But it looks like students of higher classes are being benefited more than the physiology students, because I have not got any what you call queries from physiology exam going students, but all the congratulations and also the queries I am getting is from seniors. It's also a good thing, and I thank NRI students from Vizag who have told their faculty that these classes were helping them a lot, because he had messaged me thanking on behalf of the students. But today we are going to paper 1, that is cardiovascular system. And here all the cases which have been given are mostly myocardial infarction, then hypovolemic shock and heart failure. Though other cases are there, I'll be concentrating on these 3 because these are important for all years. Right from first year to final year, you will be getting cases of shock. So I'll be briefly touching about the treatment also. So if you have any doubt, you can message me later on. The first case, a 58-year-old man presents to the emergency department with severe crushing substernal pain, chest pain radiating to his left arm and jaw. So if you have this crushing substernal chest pain radiating to his left arm and jaw, you can happily assume that it could be myocardial infarction. The pain began suddenly about 45 minutes ago while he was climbing the stairs. He is diaphoretic. Diaphoretic means he's sweating a lot. That is because of the sympathetic overactivity. Diaphoretic means sweating a lot. Pale and anxious. In the history, he has been a smoker of 30 pack years. Hypertension for 10 years, which was poorly controlled. That means he was not very regular with his medication. But he has no previous history of myocardial infarction. And on examination, he is a hypertensive with a blood pressure of 160 by 95 millimeters of mercury. His heart rate is 105 beats per minute. That means he is tachycardic. Generally, a patient with MI will become tachycardic because he is having pain. And also there is an increase in the sympathetic activity. So this is the cause of the increased heart rate, 105 beats per minute. Respiratory rate is 22 breaths per minute. So respiratory rate is also higher because of the pain. All this is because of the pain. Oxygen saturation 93% on room air. So it is less than 94%. Investigations, ST segment, okay. Cardiac examination, normal heart sounds, no murmurs. Investigations, ECG, ST segment elevations in leads 2, 3 and AVF. I think all of you know in a 12 lead ECG, the first row will be having 1, 2 and 3. Next row will be having AVR, AVF and AVL. Next will be V1, V2, V3. The last one will be V4, V5, V6. Serum troponin I is elevated. CKMB is elevated. So the diagnosis is acute ST elevation myocardial infarction, which is called as STEMI, involving the inferior wall. Inferior wall you are telling because leads 2, 3 and AVF are involved. So 2, 3 are the lower two leads in the first row and AVF is the lowest lead in the second row. So these lower leads, if they are involved with ST segment elevation, that is an inferior wall. Inferior wall is supplied by the right coronary artery. You have to remember this. Inferior wall is supplied by the right coronary artery. So now let us go into the questions. But here remember, crushing substernal chest pain radiating to his left arm and jaw. This is called, this pain is because of the referred pain. This is called a referred pain. It began 45 minutes ago while he was climbing stairs. Then smoker. Generally, if they are a smoker, vasoconstriction is the common cause. Hypertension, because of this, there would have been a increase in his left ventricular mass also. Then hypertensive, heart rate, I told you heart rate and respiratory rate is because of the pain. His sympathetic activity is high. Oxygen saturation is 93. ST segment elevation leads 2, 3 and AVF. So 2, 3 and AVF are the lower leads. That means the wall affected is the inferior wall. And you have to remember, inferior wall is supplied by the right coronary artery. Now, what is the underlying pathophysiological mechanism causing myocardial infarction? So why does the person get myocardial infarction? Myocardial infarction occurs when a coronary artery is occluded. So it has to be occluded totally. If it is not occluded and there is a partial block, there may be having angina. Angina means when he is walking, there will be pain. After when he takes rest, the pain will go. So there is no total occlusion. There is only a decrease in the blood supply, which is causing a partial ischemia. But here, the coronary artery is occluded. So I think you know the difference between angina, which is the pain which is there when the person is exercising, or myocardial infarction, where the pain is severe, substernal, and it is crushing. Usually by rupture of an atherosclerotic plaque, followed by thrombus formation. So you can see in this picture, there is a rupture of that with the formation of thrombus. leading to cessation of blood flow, ischemia, and eventual necrosis of the cardiac myocytes. Remember, if there is a necrosis, that part of the heart is damaged. So the necrosis is the cause of the pain. Understood? Only if there is a decrease in the blood supply and the person is having angina, there may be no necrosis. But in MI, there is a complete necrosis of the heart muscle due to prolonged oxygen deprivation. So what is the underlying pathology? There is a complete cessation of blood flow in the coronary artery. And here it's the right coronary artery because there is a rupture of the atherosclerotic plaque and there is a formation of a thrombus. So remember, whenever a patient is having severe chest pain and there is an ST elevation, immediately you can think of giving him certain things, certain drugs like aspirin, so that this thrombus will not be formed properly. That means for the formation of a thrombus, you require platelets, and aspirin will prevent the platelets from aggregating. So you can give that till he goes to the hospital. Why do serum troponin I levels rise after MI, and why are they clinically important? So this picture is showing what rises and for how long. This is very important. Troponin I will rise immediately and will be like that for 7 days. It is a cardiac specific protein involved in muscle contraction. I think all of you know. Troponin is a muscle contracting protein. When cardiac myocytes undergo necrosis, cell membrane integrity is lost. I told you necrosis means there is a destruction of the cells. So cell membrane integrity is lost, releasing troponin into the bloodstream. So from the myocyte, this troponin is going to enter into the bloodstream. Troponin I is highly specific and sensitive for myocardial injury. So this is a multiple choice question. What is the cardiac biomarker which is highly specific and sensitive for myocardial injury? That is troponin I, and remains elevated for 7 to 10 days, making it an important biomarker for diagnosis and follow-up. See, I told you 5 questions in the MCQs also will be case-based. In addition to the 5 questions in the main paper, 5 questions in the MCQs also will be case-based. So you have to remember these points also. And whenever I have put why, that means it is a reasoning question. Understood? So any of these questions can be given as a reasoning question for 3 marks. So everything is important. Why is ST segment elevation seen in certain ECG leads during STEMI? So you can see here, that is the P wave, that's the Q wave, R, S, and the J point is raised. So that is called ST elevation. In the second picture, there is the elevation of the J point. The elevation occurs in leads that face the injured myocardial region. That means in the leads which are capturing the activity, the electrical activity of the heart, in those leads, there will be a shift of ST. It is not that all leads will be having an ST segment elevation. Suppose it is the anterior, there will be ST elevations in certain leads. If it is lateral, there will be elevation in V5, V6. Like that, in certain leads only, the ST elevation is there. It is not present in all leads. Why? The elevation occurs in leads that face the injured myocardial region due to an injury current shifting the ST segment upward. See, all these P waves, QRS complex, T waves are electrical activity. They represents the electrical activity. P wave represents atrial depolarization. QRS represents ventricular depolarization. T wave represents ventricular repolarization. See, in the exam also, many of you, if we ask you, what does the P wave represent? You are telling atrial systole. That is absolutely wrong. Systole and diastole are mechanical activity, whereas ECG does not represent the mechanical activity. It only represents the electrical activity of the heart. Understood? So whenever they ask you what does the P wave represent, you have to tell atrial depolarization. QRS, ventricular depolarization. T wave, ventricular repolarization. Then what happened to the atrial repolarization? That is masked by the QRS complex. Why is it masked by the QRS complex? Because the ventricular muscle mass is bigger than the atrial muscle mass. So this electrical activity will mask the small electrical activity of the atria. So this is the injury current. In this case, leads to 3 and AVF correspond to the inferior wall supplied by the right coronary artery. So I have repeated so many times, leads to 3 AVF corresponds to the inferior wall supplied by the right coronary artery. So STEMI I have been telling, isn't it? There is some other thing called NSTEMI. That means the ST elevation, non-ST elevated myocardial infarction. There is no ST elevation in those. Then how can you make out whether it is a myocardial infarction? If there is no elevation of the ST segment, how can you make out? So that is why it is very important to look at three things. One is signs and symptoms. Like I told you, severe chest pain, which is crushing. It may be radiating to the neck. It may be radiating to the back. It may be radiating to the left hand. It may be going to the little finger. All these are radiating pains. These are called referred pains. And the person will be diaphoretic. He'll be having increased sweating, tachycardic. And some people will be having hypotension. Remember, some people will be having hypotension. That is more severe, especially in certain MIs. The person will be hypotensive. Because when a person gets a MI, one tablet which is given to cause vasodilatation is called nitroglycerin. I told you, aspirin is given to break down the thrombus or not allow the thrombus to form, whereas nitroglycerin is given to cause vasodilatation. So in this patient, we can give because there is a hypertension. But suppose the patient is having hypotension, then we should not give nitroglycerin because of vasodilatation, the patient may become more hypotensive. So nitroglycerin should not be given in a person who is hypotensive and is having a MI. But in this patient, because he is having hypertension, you can give nitroglycerin. How does prolonged ischemia lead to irreversible myocardial damage at the cellular level? So this is also a reasoning question. After 20 to 30 minutes of severe ischemia, ATP depletion, the ATP comes down, becomes critical for the sodium potassium pump failure. That means the sodium potassium pump is an active pump. It requires ATP and ATP is reduced because of the ischemia. Leads to cellular swelling. See, ATP, a sodium potassium pump, will be sending out the sodium and bringing in potassium. When it stops, there will be a cellular swelling. Calcium overload activates proteases. So this you have to remember. ATP is not only required for contraction, it is also required for relaxation because the calcium which is present in the cell is taken into the sarcoplasmic reticulum when the ATP is present. When the ATP is not there, it stays back in the sarcoplasm. So this causes an overload of calcium. Calcium overload activates proteases and mitochondrial damage triggers apoptosis and necrosis. So this is the reason for necrosis. After some time, what will happen? Severe ischemia is there, ATP is reduced, sodium potassium pump does not work, cellular swelling occurs, calcium overload is present, proteases are activated, and mitochondrial damage triggers apoptosis and necrosis. So the cell membrane rupture, releasing intracellular contents, making the damage irreversible. This is the thing which causes the pain also. Remember, here I told you it is myocardial infarction where there is a necrosis. But in ischemia, there will not be any necrosis in the beginning. So then what is the change which happens in the ECG? If there is a necrosis, I told you, there will be an ST elevation. But if there is ischemia, there will be an ST depression. Understood? So in the ECG, if you are seeing a depression, that is not a MI, that is a ischemia which is occurring, which may later on become an MI. But at present, if it is having a depression, that means it is an ischemia. Why might a patient with inferior wall MI develop bradycardia or hypotension? This is important. Inferior wall MI may develop bradycardia or hypotension. The right coronary artery often supplies the SA node and AV node. Ischemia in this region can impair conduction, causing bradyarrhythmias. So when it causes a bradyarrhythmia, the heart rate is reduced. Additionally, Involvement of the right ventricle can reduce preload and cardiac output, leading to hypotension. So, what is preload? Preload is the load that is present before the contraction. Afterload is the present which it has to overcome to send the blood out of the heart. So, the right ventricle can reduce the preload and cardiac output, leading to hypotension. So, remember, because it is the right coronary artery, if the SA node and the AB node are also involved, then there will be bradycardia and hypotension. If the hypotension is there, you should not give nitroglycerin. So, what have you understood now? MI can be made out only if you are doing three things. One is clinical signs and symptoms. Second is ECG. Third is biomarkers in the blood. So sometimes what will happen? Signs and symptoms will be mild. ECG there will be a NSTEMI. That means there will not be any ST elevated myocardial infarction. You may think that the patient is not having MI. But when you do the blood test, if there is a raise in the troponin I, remember that means it is a myocardial infarction. So all the three tests have to be done, have to be taken into consideration to call it a MI. So in some cases, in MI also, there is no ST elevation because ST elevation, I told you, happens when the necrosis is transmural. That means from above downwards, the whole part of the heart is necrosed. Whereas a part of the heart, suppose it is necrosed, you may not be having a ST elevation. So what you have to understand is all the three have to be taken into consideration. So what are the three things? Clinical signs and symptoms. Second one is the ECG. Third one is the blood. That is the troponin, cardiac blood. So that is about MI. So the next case, a 28-year-old man is brought to the emergency department after a motorcycle accident. Okay, if suppose they ask MI treatment also, which they should not ask physiology people, sometimes they are asking the treatment. Understood? So MI will be treated after coming to the hospital by giving tissue plasminogen activator injection. So that is going to first try to remove the clot. Afterwards, there will be a requirement of a stent to first an angiogram is done and a stent is either put or a bypass surgery. If all the three vessels are blocked, a bypass surgery. If only one vessel is blocked and you can put a stent, they put a stent to get back the circulation. So that is the treatment if they ask. TPA, that you have to remember. Tissue plasminogen activator is an injection that is given IV for dissolving the clot. So the clot which is formed is going to be dissolved. Whereas what is the first aid that you do at home? You don't allow the patient to walk. This is very, very important. A person with MI should never be made to walk. Why? If he is made to walk, what will happen? The oxygen demand of the heart will increase and there will be a greater area of damage. So he has to be carried. One of the common causes of death is the patient is made to walk. They bring him till the hospital and because there is no stretcher or any wheelchair, they ask the patient to rush to the casualty and he comes to the casualty and dies. So remember, O is oxygen. That means he should not be made to walk. He should be carried. Second one is nitroglycerin. Nitroglycerin is put sublingually. That means it is put below the tongue. Why is it put below the tongue? Because it is absorbed through the saliva and it will cause vasodilatation. A is aspirin. Aspirin, generally 325 milligrams of aspirin. But remember, aspirin has to be chewed. Navilivingali. Why it should be chewed? Because normally the food substances are absorbed from the intestines, but aspirin can be absorbed from the stomach. So it is very important that he choose the tablet or he can dissolve the tablet in water and drink. Understood? And M is move him to the hospital within 1 hour. This is called golden hour. So this is the first aid you give. So easily we can remember Onam. Onam is the function, festival, isn't it? O, oxygen. That means don't make him move. N is nitroglycerin. tablet which has to be put sublingually, which causes vasodilation. A is aspirin, 325 milligrams, to be chewed or taken with dissolved in water. M is moving to the hospital within 1 hour. In the hospital, what do? They give the TPA to dissolve the clot, and they either put a stent or a bypass surgery after doing an angiogram by making out what is the clot. So that is the treatment. Now we come to the next one. A 28-year-old man is brought to the emergency department after a motorcycle accident. He is pale, sweaty, and confused. Vital signs: blood pressure is 80 by 50 millimeters of mercury. So it is hypotensive. Heart rate 130 beats per minute. So there is tachycardia. Respiratory rate 26 per minute, slightly increased. Temperature 36.5 degrees centigrade. Oxygen saturation 96% on room air. On examination, his skin is cool and clammy with delayed capillary refill. See, normally when you press the thumb, nail of the thumb, it becomes white, and if you remove it within 2 seconds, it becomes pink in color. You cannot try it in your thumb. You press the thumb with the other finger and leave it. Within 2 seconds, that capillary refill will happen. But if it is delayed, that means the capillary refill takes more than 3 seconds. That means the patient is in shock. His jugular veins are flat. That means it is not distended. There is no right atrial increase in pressure. And there is a deep laceration on his thigh. That means there is a deep cut on his thigh with active bleeding. That means he is bleeding from this laceration on the thigh. What does the laboratory test show? Hemoglobin is 8 grams per deciliter. It means hemoglobin is low. He has become anemic. Hematocrit is 25%. That's also low. Lactate is 4.5 millimoles per liter. That means it is elevated. Arterial blood gas, pH is 7.30. That means he is acidic. PaCO2, 32 millimeters of mercury. So it is low. Bicarbonate, 16 milliequivalents per liter. That is also low. Okay. See, whenever a case is given to you, read the whole case. Just don't look at 2 or 3 things and come to a diagnosis. Understood? That is very, very important, because I told you yesterday, isn't it? So many cases are there where there is an increase in the blood sugar. Just by looking at the blood sugar, don't think that it is diabetes mellitus. Read the whole case, understand the whole thing, try to put 2 or 3 diagnoses, then try to fix your diagnosis to one after going through the whole thing. So what are the things that is important here? A young person is brought to the emergency department after a motorcycle accident. So it is a trauma case because it's a motorcycle accident. He is pale, sweaty, and confused. So pale, sweaty, and confused could be because paleness could be because of the sympathetic overactivity. Whenever the person is having a pain, motorcycle accident, he might be having pain, he may be pale, or the blood has gone out. So that is also one reason for pale. Then sweaty. See, remember, sympathetic activity on the sweat glands is increasing the sweat content. That is because these sweat glands are having acetylcholine, which are also connected to the sympathetic system. So, sympathetic system has both cholinergic as well as adrenergic neurotransmitters. So, the sweat glands have acetylcholine as the neurotransmitter, but it is sympathetic. So, it is sweaty. And the patient is confused. Confused because the brain is not receiving sufficient blood. So, that could be the reason that he is confused. Vital signs: blood pressure is 80 by 50. So, remember, whenever the blood pressure goes below 90 millimeters mercury of systolic, if systolic blood pressure has gone below 90 millimeters of mercury, that means the patient is in shock. That is one easy way, easy sign you can make out if the patient is in shock or not. So here the blood pressure is 80 by 50 millimeters of mercury. So he's in shock. Heart rate is 130 beats per minute. So the body has compensated this low blood pressure by an increase in the heart rate. I told you sympathetic overactivity. So the heart rate is increased. So that body will be able to get the cardiac output. See, cardiac output is heart rate into stroke volume. Because the blood pressure is low, stroke volume will become low. So the heart rate will try to compensate it. Respiratory rate is 26 per minute. That means the respiratory rate has increased to compensate for the acidosis which has occurred. Temperature 36.5. Oxygen saturation is normal. Sometimes the oxygen saturation also comes down. You have to see that also. On examination, his skin is cool and clammy. Okay. So what do you mean by cool and clammy? Cool means it is cold. Why is it cold? Because of vasoconstriction. Clammy means you have to remember, if you touch the shell అంటే ఈ శంఖం లాంటివి ఉంటాయి కదా ఆన్ ద సీషోర్ it will be a little wet sensation వస్తుంది అన్నమాట. That is called clammy. So this is because of the sympathetic overactivity. I told you vasoconstriction and increase in sweat are sympathetic activity. So both these will cause the skin to be cool and clammy. With delayed capillary refill, I told you the normal capillary refill time is less than 2 seconds. If there is a delay in the capillary refill, if it is more than 3 seconds, that means the patient is in shock. So here you can easily make out blood pressure is low, that means there is a shock, and capillary refill time is more than 3 seconds. His jugular veins are flat and there is a deep laceration on his thigh with active bleeding. So you can see that he's bleeding through the thigh. So laboratory tests show hemoglobin 8 grams per liter. He has become anemic. Hematocrit 25, lactate 4.5 ml. So all these are positive. So anyone could like to make a diagnosis with this data? Anyone? Srija? Very good. So it is shock, hypovolemic shock. Specifically, you have to tell it is hypovolemic shock because you say that this shock is caused by the laceration on his thigh with active bleeding. As you all know, what are the types of shock? Most commonly, which we encounter in the hospital is hypovolemic shock. What are the other types of shock? Anyone? So cardiogenic shock, septic shock, obstructive shock. Very good. So in almost all types of shock, the skin is cool and clammy. But in septic shock or anaphylactic shock, there is vasodilatation. So there you have a warm skin. That's why it's called warm shock. Understood? In anaphylactic shock also there is vasodilatation. In septic shock also there is vasodilatation. So there the skin need not be cool and clammy. There the skin will be hot. That's why it is called warm shock. Whereas the rest of the shocks are called cold shocks. Understood? So what do you mean by cardiogenic shock? Suppose the patient has got MI and is not able to pump the blood properly. That is called cardiogenic shock. Suppose the patient is having a pulmonary embolus or he's having what you call cardiac tamponade. That means the heart is not able to contract properly because there is some fluid in between the extra fluid in between the pericardium and the heart. So that is called cardiac tamponade. If there is a cardiac tamponade, the heart will not be able to pump properly. These are examples of obstructive shock. Understood? These are obstructive shock. Then this is hypovolemic shock. Whenever there is a bees which sting or he takes a drug and he has an anaphylactic reaction. That is all anaphylactic shock, all that. And burns, remember, burns also causes hypovolemic shock. There is a loss of fluid. In the same way, diarrhea. The diarrhea also causes hypovolemic shock. So the questions: explain how acute blood loss in this patient leads to observed drop in blood pressure and elevated heart rate. Explain how acute blood loss in this patient leads to observed drop in blood pressure and elevated heart rate. Then, which autonomic and hormonal response, this is very, very important. Which autonomic and hormonal responses are activated in hypovolemic shock, and how do they attempt to restore homeostasis? See, in today's cases, these cases are entirely dependent upon the understanding of the case. It is not memory based. Here it is concept oriented. That's why it will taking a little time. So these cases, unless you understand everything properly, you will not be able to give a correct treatment. So how does prolonged hypovolemia affect tissue perfusion and cellular metabolism at the microvascular level? What is the effects of hypovolemia? That is ischemia. Then arterial blood gas interpretation. What type of acid-base disturbance is present and what is its primary cause in this patient? See, I'll be taking a detailed class, or I'll be asking someone else to take a detailed class on acid-base disturbance, because this is one concept which every student should have. In the emergency department, this is the only thing which will help the patient. Understood? This in COVID, I remember this, most of the people died because of acidosis. What type of acid-base disturbance is present? You should be make out whether it's a respiratory or a metabolic. Understood? Because we were giving steroids to them, they were developing diabetes, they were getting acidosis. Because of the changes in the lungs, they were getting respiratory acidosis. Both the things were there. It's called mixed acidosis. Clinical management, outline the immediate steps in managing hypovolemic shock. This is very, very important. Hypovolemic shock management. Okay. Now we'll go to each one of them. Pathophysiology, acute blood loss reduces circulating blood volume, isn't it? Normally it's 5 liters. That blood volume will be reduced. That causes a decrease in the venous return, preload. See, here I told you the jugular vein is flat. What do you mean by jugular vein is flat? That means the preload is low. So decreased venous return, which reduces the stroke volume. I told you, because the stroke volume is reduced, there was a compensatory increase in the heart rate. That's why this patient was having tachycardia. This is the negative feedback. But once the compensatory mechanisms fail, the person will go to a positive feedback, and finally there will be bradycardia and the person will die. Understood? So only if there is a compensation for the shock, he will be having tachycardia. That is because there is a negative feedback. But if the positive feedback sets in, the patient will die. Since mean arterial pressure is equal to cardiac output into total peripheral resistance, the fall in cardiac output drops the mean arterial pressure. The body responds with reflex tachycardia via the baroreceptor reflex to partially maintain the cardiac output, which explains the patient's heart rate of 130 beats per minute. So this is very easy to understand why there is a increase in the heart rate and why there is a flat jugular venous pulse. Then compensatory mechanisms, neural, baroreceptor reflex. This is what I told you just now. Parasympathetic activity decreases. That means the vagal tone is reduced. Sympathetic activity increases. Parasympathetic activity decreases because of the baroreceptor reflex. There is an increase in the sympathetic activity. Parasympathetic activity decreases. Vagal tone will decrease. Then hormonal. Epinephrine and norepinephrine, which come from the adrenal medulla, increase the heart rate, contractility, and cause vasoconstriction. Then one more important thing is the renin, angiotensin, aldosterone system. See, this is an important question for you even without a case. Blood pressure regulation is an important question for you. It could either be short-term regulation or long-term regulation. Most of the times they have asked you long-term regulation. So you have to write about the renin, angiotensin, aldosterone system. So it gets activated. Angiotensin 2 causes vasoconstriction. Aldosterone increases sodium and water absorption. ADH, vasopressin release, water retention, and vasoconstriction. I hope you know about the renin, angiotensin, aldosterone system. So renin is produced by the juxtaglomerular apparatus. When is it produced? Whenever there is a decrease in the blood pressure, the renin is produced in the kidney, okay, by the juxtaglomerular apparatus. What does this do? There is another substance which is called angiotensinogen. Angiotensinogen is produced in the liver. This angiotensinogen is converted to angiotensin 1 by renin. Understood? So, where is renin produced? Renin is produced by the juxtaglomerular apparatus in the kidney. When is it produced? Whenever the juxtaglomerular apparatus will feel that there is a fall in the BP, it produces renin. What does renin do? It converts angiotensinogen, which is produced in the liver, to angiotensin 1. This angiotensin 1 is converted to angiotensin 2 by a substance which is called angiotensin converting enzymes, which is released from the pulmonary circulation. So, how is angiotensin 1 converted to angiotensin 2? By ACE, that is angiotensin converting enzymes. See, angiotensin 1 and angiotensin 2 are severe vasoconstrictors. Understood? They are severe vasoconstrictors. So, they cause vasoconstriction. There is one more function for angiotensin 2. What is that? This will stimulate the adrenal cortex to produce a mineralocorticoid which is called aldosterone. So, what are the functions of angiotensin 2? It causes vasoconstriction and also stimulates the adrenal cortex to produce aldosterone. What is the function of aldosterone? It increases the sodium reabsorption. So, aldosterone increases the sodium reabsorption. So, along with the sodium, water is also reabsorbed. Understood? Water is also reabsorbed. ADH also is released, water retention and vasoconstriction is seen because ADH is called vasopressin also because of its vasoconstriction effect. So, I hope you understood about the renin, angiotensin, aldosterone system. Renin is produced in the kidney, angiotensinogen is produced in the liver, angiotensinogen is converted to angiotensin by renin, angiotensin 1 is converted to angiotensin 2 by ACE, that is the angiotensin converting enzymes from the pulmonary arteries. Then this angiotensin 2 causes vasoconstriction. It also stimulates the adrenal cortex to produce aldosterone. This aldosterone increases the sodium reabsorption. When the sodium is reabsorbed, water will passively be reabsorbed. Then ADH, vasopressin, is also released. That causes vasoretention and vasoconstriction. Yesterday we talked about ADH, isn't it? Yeah. Then what happens to the microcirculation? Early shock. What happens? Arteriolar vasoconstriction shunts the blood away from skin, GI tract and kidneys towards vital organs, that is the heart and the brain. So remember, the body, to preserve life, will try to cause the blood to flow to important organs, and that's why there is a vasoconstriction from the skin, GI tract and kidneys. Because of this vasoconstriction, I told you the paleness could be there in the skin. One is vasoconstriction. Second thing is, so much of blood has been lost, isn't it? So 8 grams was the hemoglobin. So that also causes the paleness of the skin. So vasoconstriction is there from the skin, GI tract and the kidneys towards vital organs like the heart and brain. Prolonged hypovolemia. In the initial stage, I told you, first thing happens. If there is a prolonged hypovolemia, capillary hydrostatic pressure is decreased. I hope you know two things: capillary hydrostatic pressure, oncotic pressure. Oncotic pressure is because of the plasma proteins that prevents the fluid from entering the tissue spaces. Hydrostatic pressure increases the tissue to go, favors the tissue to go, the fluid to go to the tissues. There is a decrease in the capillary hydrostatic pressure, which causes cellular hypoxia. There is a shift to anaerobic glycolysis. This is important. Because of the cellular hypoxia, there is a shift to anaerobic glycolysis, which causes the lactic acidosis. This is the cause of acidosis in shock. There is an accumulation of lactate. Why is there an accumulation of lactate? Because there is a shift to the anaerobic glycolysis. So, why is there a shift to anaerobic glycolysis? Because of the hypoxia. Okay? Yeah. Then persistent shock. After a long time, what will happen? Endothelial damage, that means the endothelium is broken down, increased permeability, leakage of plasma proteins, worsening of edema, and further hypoperfusion. This becomes a vicious cycle. That means hypoperfusion will cause endothelial damage, increase in the permeability, leakage of plasma proteins, worsening of edema. Again, it causes hypoperfusion. So, this is like a circle and the patient will die. This is a positive feedback. Once he goes into the persistent shock, it is very difficult to recover the patient. So that is called refractory shock. Understood? Refractory shock means the patient generally will not be able to survive. So this is seen in septic shock, in all types of shock. That means we have to see that he does not go into refractory shock. Then arteriolar blood gas interpretation. pH normally is 7.4. So here it is less. That means pH is less means increased in hydrogen ion concentration, which is called acidemia. Bicarbonate 16 milliequivalents per liter, low. So bicarbonate low means metabolic acidosis. Why is there a metabolic acidosis here? Because the lactate has increased. Why does the lactate increase? Because of the ischemia. It has shifted to anaerobic glycolysis. Then PaCO2 32 millimeters of mercury, low. Okay. See, normally it should be about 40 millimeters of mercury. Why? Because I told you the respiratory rate was high there. So hyperventilation. The patient is breathing heavily. When he's breathing heavily, what happens? The carbon dioxide is going to come out from the lungs. When this happens, there will be a decrease in the partial pressure of carbon dioxide. So this is called compensatory respiratory alkalosis because of hyperventilation. Actually, it is a metabolic acidosis. But why is the partial pressure of carbon dioxide low? Because of the compensatory respiratory alkalosis, hyperventilation. So it's a mixed type. Primary cause is lactic acidosis. So it's a metabolic acidosis from tissue hyperperfusion and anaerobic metabolism. Hope you have understood this blood gas interpretation. 7.3 means acidemia. Why is bicarbonate low? Because of metabolic acidosis. Because of the lactic acid concentration in the blood as a result of tissue hyperperfusion and anaerobic metabolism. Partial pressure of carbon dioxide. Why is it low? Because the person is breathing heavily. There is hyperventilation, which causes compensatory respiratory alkalosis. This I will take about 5 minutes. See, any case, when you see it for the first time, you always have to follow a protocol. That is called doctor's ABC. First, you see whether the patient is in jail. Suppose this patient was found on the road. Don't start treating him on the road. You bring him to the side of the road. So after bringing him to the side of the road, you have brought him to a safe place. So first thing is bring him to a safe place. Second thing is ask for 108 to come. Understood? Check for the response. If he's saying, okay, I'm all right, call for 108. So triaging, you should know what is triaging. All the seniors, you should know what is triaging. Understood? Whom you have to treat, whom you need not treat. If there is a mass casualty. So that is called triaging. Then the immediate priorities are A, B, C. Airway, breathing and circulation. Airway, secure the airway if there is a mental status worsens. How do you know whether the airway is open or not? One simple way is ask the patient to talk. If he is able to talk, that means his airway is open, he is not hypoxic. Ask him what is your name, ఈ పేరేంటి నా పేరు సో అండ్ సో అని చెప్పాడు అనుకోండి దట్ మీన్స్ హిస్ ఎయిర్వే ఇస్ ఓపెన్ ఇన్స్టెడ్ ఆఫ్ దట్ హీ సేస్ నా పేరు రాజమండ్రి దట్ మీన్స్ he is not giving a correct answer, so he might be in hypoxia. So check for the airway, or sometimes you'll be able to see some blood or secretions in the mouth itself. When you open the mouth, you'll be able to see the secretions. Then you have to suction it and open the airway. But if he's unconscious, remember, you have to open the airway because when his person becomes unconscious, the tongue will be blocking his airway. So you have to open it by a method which is called head tilt, chin lift. Okay? Then breathing, check his partial pressure of oxygen, see whether both sides of the chest are moving normally or not. Do a simple auscultation, see whether both sides are, you are able to hear the breath sounds. Give supplemental oxygen if the partial pressure is below 94. Okay. Circulation, control the external bleeding, direct pressure or tourniquet. But remember, if you tie a tourniquet gatti katte on one. If you tie a tourniquet, you have to keep on releasing it every 2 minutes, 20 minutes. Why? Because every 20 minutes, you have to keep the area with nutrition. If you are keeping a tourniquet, that area below the tourniquet will not be getting the nutrition. That means it becomes gangrenous by the time you go to the hospital. So the tourniquet has to be loosened every 20 minutes for a little time. Then, so you have checked the ABC, volume resuscitation. See, many students, what they are writing is blood transfusion is the treatment. See, for blood transfusion, the person's blood has to be taken. It has to be sent for culture system, blood grouping and typing. It will all take time. By the time this fellow will be dead. So don't write blood transfusion as the first line of treatment. First you check the ABC. First you increase the volume of blood. How do you do that? By putting two large bore veins, needles. Understood? 14 and 16 are large bore. A chetikoti, E chetikoti. For that hand and this hand. 14 to 16 age IV lines you put. Rapid infusion of isotonic crystalloids. So remember, this is very, very important. That hand and this hand, IV lines you have put. I think all the people who came from Uzbekistan, you have learned how to put a IV line, isn't it? So two IV line needles are put on that side and this side. Then normal saline or ringer lactate is sent. 20 ml per kg body weight. Okay. Blood transfusion, if ongoing hemorrhage and the hemoglobin is less than 7 to 8 grams. By this time, you would have sent the blood for cross-matching or typing. You would have got the blood and you can do the blood transfusion. But remember, you have to continuously monitor the blood pressure, heart rate, urine output. If the urine output is decreasing, that means the patient is going to shock. The shock is persisting. So the urine output has to increase. Why does the urine output decrease? Because of the severe vasoconstriction. I told you, the skin, the GI tract, the kidneys, there is vasoconstriction to send the blood to the brain and the heart. That's why this vasoconstriction is removed only when the shock is treated. So you should be having a normal urine output. Treat the underlying cause. Surgical repair of laceration, stop the bleeding. See, it's a, suppose here the bleeding is through the thigh. You can see, make out the bleeding. Sometimes the bleeding is inside the abdomen. Understood? Especially when a person is driving a car and he has an accident and he is not wearing a seat belt. That steering will come and hit him on the chest and the abdomen. So there may be internal bleeding. So there is a ultrasound which is called FAST, F-A-S-T, which is done to make out internal bleeding. This is also important. I think I'll be taking one trauma class completely, separately for you for about 2 days. 2 days it will take. So later on, if NMO permits me, I'll be able to take this later on. I'll design those things. Okay? Treat the underlying cause. Avoid delays in definitive hemorrhagic control. Stop the leak before filling the tank. That means you have to stop the bleeding. Otherwise, whatever you are doing is going to go out. So this is about hypovolemic shock. Okay. And the last case for today, a 64-year-old male. This has come only once. They have given this question only once. MI as well as hypovolemic shock has been given large number of times. So paper 1, this comes. A 64-year-old male presents to the clinic with progressive shortness of breath over the last 6 months. It means he is becoming dyspneic progressively. He reports orthopnea. Orthopnea means he is having difficulty in breathing only when he is lying down. If he is sitting, there is no breathlessness. So he reports orthopnea, needing 2 pillows to sleep. Paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea means, paroxysmal means occasionally. Nocturnal means night. So he is having dyspnea in the nights for some time. After that, it's going. Again, he's having it for some time. Again, it's going. So that is called paroxysmal nocturnal dyspnea. And increasing fatigue. He's feeling weaker and weaker. So increasing fatigue. He also notices swelling in his ankles by the evening. That means there is fluid accumulation in the ankles. See, I told you about edema. Pitting edema, non-pitting edema. Non-pitting edema, where did I tell you is present? People who came on the first day. Non-pitting edema, where is it present? Very good. Very good. So in mixed edema, you have non-pitting edema. Okay. So that is seen in hypothyroidism. So in mixed edema, you had non-pitting edema. You also have non-pitting edema whenever the lymphatics are blocked. Understood? There's a disease which is called filariasis. There also the lymphatic is blocked and you have a non-pitting edema. Wherever fluid is accumulating, water is accumulating, you have pitting edema. So he also notices swelling in his ankles by the evening. Past medical history, hypertension, 20 years, which is poorly controlled. Myocardial infarction, 3 years ago, type 2 diabetes mellitus. Okay, he is a 64-year-old fellow with everything. Hypertension, myocardial infarction, diabetes mellitus, all the non-communicable diseases. He is having all the three. On examination, this is the common presentation nowadays. Whenever a person is coming, he is both hypertensive as well as diabetic. And some people will be having old history of myocardial infarction also. I think you might have seen these cases. On examination, blood pressure is 150-90 millimeters of mercury. That means he is hypertensive. Pulse is 96 beats per minute. Though it is not tachycardia, his heart rate is fast, regular. Okay. So there is no arrhythmia. Jugular venous distension at 45 degrees. So jugular venous pressure is raised. Remember, for making out a jugular venous pressure, you have to keep the patient at 45 degrees. Then only if you are able to see the jugular venous pressure, jugular venous pulse, then you can say that the jugular venous pulse is raised. So that indicates the right atrial pressure. Remember, what does JVP indicate? It indicates the right atrial pressure. Normally, you should not be able to see the JVP above the clavicle. But if you keep him at 45 degrees and you are seeing the JVP, that means the right atrial pressure is raised. Then bilateral basal lung crackles. That means he is having pulmonary edema also. Bilateral basal lung crackles. Normal, you should be able to hear a normal vesicular breath sound, isn't it? So when the fluid is started accumulating in the lungs, you can hear lung crackles. Crackle means, suppose a dry leaf, you are breaking a dry leaf. One sound will be coming, isn't it? When you are breaking a dry leaf, one sound will come. That is a crackle. So pitting edema in both ankles. S3 heart sound is present. Remember, S3 heart sound and heart gallop. S3 heart sound is present. Investigations. BNP, brain natriuretic peptide, is elevated. See, remember, this is a very characteristic feature of heart failure. BNP is elevated. Echocardiography, left ventricular ejection fraction is 35%. So it is very, very low. Left ventricular ejection fraction is 35%. Dilated left ventricle, because the hypertension, you might be having a dilated left ventricle. Chest X-ray, cardiomegaly, and pulmonary congestion. So I told you bilateral basal lung crackles are present. That could be because of the pulmonary congestion, cardiomegaly, dilated left ventricle. So when he's having a cardiomegaly on checking the apex speed goes more laterally. Understood? Normally, where is the apex speed? The apex speed is present about half an inch medial to the midclavicular line. Here, when there is a dilated left ventricle, it will be lateral to the midclavicular line. So it may be in the fifth intercostal space, but it will be lateral to the midclavicular line. You can make out by clinical examination also. Cardiomegaly. So what are the things here? Progressive shortness of breath, which is slowly progressive. For 6 months, he is having, it's increasing. So the shortness of breath is increasing for the past 6 months. Orthopnea means he is feeling breathless when he is sleeping. Paroxysmal nocturnal dyspnea is he is having a dyspnea in the nights, which is more increasing fatigue. He also notices edema, swelling in his ankles, that means edema, which is pitting. He has a past history of hypertension, uncontrolled, myocardial infarction, diabetes mellitus. Examination, blood pressure. See, if you have parents, you ask them always to check their blood pressure. You check the blood pressure every year and see whether they are hypertensive, because hypertension has become a silent killer nowadays. Till they come to the hospital with MI, the patient does not know that he's having hypertension. And by the time he comes to the hospital, most of the damage is already done. So if you are an MO, you can go on doing this hypertension camps. Understood? Just keep checking everyone you come across correctly, whether he's having a hypertension or not, hmm, and give the necessary treatment by changing his lifestyle. Then you can also do the diabetes camps for type 2 diabetes. This is also a silent killer. Till they come up with some kidney failure or something or MI, they will not be knowing that they were diabetic. So you can do this in an MO. So he's a hypertensive, pulse is 96, then JVP is raised, then bilateral basal lung crackles are present, pitting edema present, S3 heart sound. Okay, we'll be discussing about this. BNP elevated. Remember this. BNP elevated means it is heart failure. Natriuretic peptide. Okay. Left ventricular ejection fraction. So this is a low cardiac output, low ejection fraction, heart failure. Low ejection fraction, heart failure. Okay. Explain why a reduced left ventricular ejection fraction leads to pulmonary congestion. Okay. This is the reasoning question. Explain why a reduced left ventricular ejection fraction leads to pulmonary congestion. See, I have taken these questions because most of these questions are reasoning questions. And this is the first time that you'll be having reasoning questions. Not only that, most of the students by heart this subject and go and write it in the examination. They have not understood it. So when they become doctors also, they are not having a complete understanding of the disease. Unless you know the physiology, you will not understand the pathology. Unless you have an understanding of physiology and pathology, you will not be able to give the correct treatment. So remember, this is very, very important for you to understand the physiological basis. Understood? Physiological basis. Then you will be understanding the pathology. That's why I told you in my previous class also. I call it physiopathology, not pathophysiology. Because the physiology changes to pathology. Explain why a reduced left ventricular ejection fraction leads to pulmonary congestion. Then, which neurohormonal systems are activated in chronic heart failure and what is their short-term versus long-term effect on cardiac function? So, again, here also, you have to know about the neurohumoral systems. Then, right-sided signs. Why does left-sided heart failure eventually cause ankle edema and jugular venous distension? That means these are all right heart failure signs, jugular venous distension. But left-sided failure also will be causing finally a right-sided. Why? S3 heart sound. What physiological mechanism produces the S3 heart sound in heart failure? I think you know about S1 and S2. What is the cause of S1 and S2? They are the closure of the AV valves and the the aortic and pulmonary valves, isn't it? S1 and S2. See, in the exam also, please don't tell S1 is heard in mitral and tricuspid area. S2 is heard in aortic and pulmonary area. Both the sounds are heard in all areas. Remember this. S1 and S2 are heard in all areas. Only thing is, S1 is heard better in the mitral and tricuspid areas. S2 is heard better in the aortic and pulmonary areas. So this you don't forget in the exam. Many students make this mistake in spite of telling it so many times. Okay. So now you should be able to tell what is the cause of S3 heart cell. Then why are ACE inhibitors beneficial in the management of this patient's condition from a physiological perspective? What is ACE? Angiotensin converting enzyme. I told you, isn't it? Angiotensinogen is converted to, angiotensin is converted to angiotensin 2 by angiotensin converting enzyme. So that inhibitor, why are ACE inhibitors beneficial in the management of this patient's condition from a physiological perspective? We will go to each one of them now. Why does a reduced left ventricular ejection fraction cause pulmonary congestion? So what does left ventricular ejection, what is the left ventricular ejection fraction? That means the amount of blood which is present in diastole. When the systole happens, some of it is going into circulation. So it is ejected out. So a fraction of it is ejected out into the aorta. From the left ventricle, it goes to the aorta. So normal it should be more than 50%. Generally it will be 60. But when it becomes less, what will happen? The amount of blood in the ventricle will become more and more. So the end diastolic volume will increase. Understood? So decrease in the stroke volume will cause the left ventricular end diastolic pressure to increase. Why? Because the volume is increasing, the end diastolic pressure is increasing. This pressure backs up into the left atrium. From the left ventricle, the left atrium also the pressure raises, which causes an increase in the left atrial pressure, which causes an increase in the pulmonary venous pressure. Because the pulmonary veins are opening into the left atrium, there is an increase in the pulmonary venous pressure. Elevated capillary hydrostatic pressure exceeds the oncotic pressure. So there is an increase in the capillary hydrostatic pressure. So what happens? Fluid will leak into the interstitial spaces and alveoli, which causes those crackles. I told you, when you are auscultating, you can hear crackles. That means there is some fluid in the alveoli. So pulmonary edema and congestion. So you should differentiate between pleural effusion and pulmonary edema. Pulmonary edema means in the parenchyma, the fluid is accumulating. Pleural effusion means the fluid is accumulating in between the pleura and the lung. Entirely different. Both are entirely different. Okay. So why does the reduced left ventricular ejection fraction cause pulmonary congestion? I think you have understood. There is a decrease in the stroke volume. What is stroke volume? The volume of blood that is ejected from the left ventricle with every systole. So a part of it remains back, which is called the end diastolic volume. Whenever there is a decrease in the stroke volume, there is an increase in the left ventricular end diastolic volume. That means there is an increase in the left ventricular end diastolic pressure. This pressure backs up into the left atrium. From the left ventricle, that pressure backs up into the left atrium. That causes an increase in the left atrial pressure. This increase in the left atrial pressure is felt in the increase in the pulmonary venous pressure, because the pulmonary veins are opening into the left atrium. So this decrease in the stroke volume is causing an increase in the pulmonary venous pressure. So then what happens? This will elevate the pulmonary capillary hydrostatic pressure more than the oncotic pressure. Then what will happen? The fluid will start leaking into the interstitial space, because the capillary hydrostatic pressure will be pushing it out, and alveoli, which causes pulmonary edema and congestion. So this is the reason of the pulmonary congestion. So the person may sometimes have hemoptysis also, or pink colored sputum or red colored sputum they'll be having. So whenever you have a pink colored sputum, not only you have to think about infections, you have to think about this condition also. Okay. Now, which neurohormonal systems are activated in chronic heart failure and their short-term versus long-term effects? Same thing. Sympathetic nervous system, increase in heart rate, contractility, and vasoconstriction. All the three. Renin, angiotensin, aldosterone mechanism. So again, I told you, where is renin secreted? Renin is secreted from the kidneys by the juxtaglomerular apparatus. What does it do? It converts the angiotensinogen, which is released from the liver, to angiotensin 1. This angiotensin 1 is converted to angiotensin 2 by what? By the angiotensin converting enzyme. What does angiotensin do? It causes vasoconstriction. It also helps in the stimulating the adrenal cortex to produce aldosterone. What does aldosterone do? Aldosterone will help with the absorption of sodium. Along with the sodium, water is also retained. ADH is also stimulated to be produced, which causes water retention. So this is the mechanism: renin, angiotensin, aldosterone system, RAS. Then short-term effect, it helps in the maintenance of BP and perfusion despite low cardiac output. See, there is a low cardiac output, but in spite of it, it will help in maintaining the blood pressure by increasing the heart rate and all that, contractility. Long-term effect, there is an increase in the afterload, the preload, which causes myocardial remodeling, fibrosis, which worsens the heart failure. See, because the afterload also increases, the preload also increases, myocardial remodeling will occur, which causes fibrosis, and the heart failure will worsen. Unless you treat it, this heart failure will go on worsening. Next question. Why does left-sided heart failure eventually cause ankle edema and jugular vein distension? Chronic increase in the pulmonary pressure. I told you how the pulmonary pressure is increased. Leads to pulmonary hypertension, right ventricular overload, right ventricular failure, increase in the right atrial pressure, increase in the systemic pressure. So this is the increase in the preload. So why is this happening? Because of pulmonary hypertension. Elevated venous hydrostatic pressure, fluid moves into interstitial tissues of dependent areas. So whenever the venous hydrostatic pressure also increases, the fluid will move into the dependent. So normally we'll be standing or sitting, isn't it? So our legs are down. So that's why the fluid accumulates in the ankles. And there is a distension of the neck veins because the right atrial pressure also is increased. Then mechanism of the S3 heart sound. See, S3 is called the ventricular gallop. I think you know what is a gallop. Gurram వెళ్తుంది కదా, a horse will go. So here it will be first sound, second sound, and third sound. That is called a ventricular gallop. Tuck, 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 tuck. The sound will be like that. Okay. Three sounds you will be hearing. This is caused by the rapid passive filling of a dilated non-compliant ventricle in early diastole. So this is not because of the closure of the valves. Remember, S3 is not, the gallop sound you are hearing is not because of the abnormal closure of the valve. It is caused by the rapid passive filling of a dilated non-compliant ventricle. So in early diastole, what will happen? The ventricle will be filled. So rapid filling of the dilated non-compliant ventricle in early diastole. So in heart failure, there is an increase in the left atrial pressure, isn't it? Why is there an increase in the left atrial pressure? Because the volume overload. Why is there a volume overload? Because the stroke volume, the ejection fraction is reduced, which causes a brisk filling, vibration of the ventricular walls, which leads to S3. So the vibration of the ventricular walls are the cause of S3. It is not the valves. It is the ventricular walls which are causing the S3. So the last question, why are ACE inhibitors, angiotensin converting enzymes, beneficial in heart failure from a physiological perspective? So it blocks the simple is it blocks the conversion of angiotensin 1 to angiotensin 2. So I told you angiotensin 2 is a more severe vasoconstrictor than angiotensin 1. So vasoconstriction is decreased and there is a decrease in the afterload. So when the afterload is decreased, there is a decrease in the aldosterone. There is a decrease in the sodium and water retention. There is a decrease in the preload. So remodeling and fibrosis, angiotensin 2 is also pro-remodeling. Remodeling means because of the increased pressure, there are some changes which happen in the heart. For example, the walls become thick. Understood? More muscle fibers are formed. This is called remodeling. Finally, it causes fibrosis. But remember, remodeling is because of angiotensin 2. It is a pro-remodeling agent. Net effect is improved cardiac output, reduced congestion, slower disease progression. So in heart failure, the drugs that are given are ACE inhibitors, which is also antihypertensive. ACE inhibitors are also antihypertensive. It is also given. Then another drug which is called digoxin is given in heart failure. But remember, I told you there is so much of fluid accumulation, so the treatment is diuretics. Understood? Last time when they gave this question in the exam, they asked for treatment, which was ridiculous. How can a first year student know the entire treatment? So they wrote something. But remember, nowadays they are asking treatment. So the basic treatment you remember. In shock also, I told you the treatment. Here also, the basic things you remember. You give oxygen, you give ACE inhibitors, you give digoxin, you give diuretics. Why you give diuretics? To remove the extra fluid. Why you give ACE inhibitors? To block the conversion of angiotensin 1 to angiotensin 2. Why do you want to stop this block? So that the vasoconstriction, afterload, all that will be reduced and this remodeling will not happen. And people who are in failure, if they are hypoxic, you have to give oxygen and rest. Okay. So actually, I had one more case, but as the time is restricted, I will be giving you the PDF of that case also. That is actually what you call hard block. It's a hard block. Hard block is also a common question which they ask you. So what I thought was later on when I have time, I will take hard block separately, tachyarrhythmia separately, then shock separately, so that it will be of help to you in your final exam for all years. Thank you very much. I'll be getting a lot of messages asking me to continue, but from next week, we are getting a new batch of students from Uzbekistan. So afterwards, within 5 days, we are getting another batch. So it's a little busy these 15 days. But thank you very much that all of you are finding it useful. In the last day, I will also, that is tomorrow, I'll try to give a feedback so that we can improve this whenever I have time. And if the National Medicos organization are interested, we can keep meeting like this occasionally and discussing certain things. Okay. So how it can be made better also, please inform. Thank you very much, Ajay, for again calling me and having these sessions. I'm seeing that with the feedback that it is of good use to them. So this was a very thoughtful action of yours. I thank the National Medicos Organization for giving me this opportunity. Thank you. Any
Thank
doubts
you
you have,
very
you can please
Yes, sir.
message me. Okay.
So, thank you very much, sir, for the presentation on cardiovascular system. On behalf of JSL Medical College Rajahmundry and the National Medicos Organization, I extend our heartfelt gratitude to Dr. Karningu Srinivas Rao sir for sharing his valuable knowledge. And we also thank Dr. Naresh sir, Dr. Sagar sir, and also Dr. S.V. Ramnamurthy sir for joining us today. Our thanks to our digital partner, Team Clirnet, and special appreciation to Mrs. Ritu and Mrs. Rimpa for the coordination and moderation. We are grateful to all participants for your active engagement. Recordings of all 4 days of sessions will be uploaded shortly to the official NMO YouTube channel for future reference. I'll end up this session by playing this Shanti mantra. Thank you.
ॐ सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः
Thank you, sir. Sir, can we
Yeah,
end up the
thank you.
session?
Yes, yes. Thank you. Thank you
Yes,
so
sir.
much.
Thank you, sir. Thank you, everyone.
So-
Rimpa, are you there?
Yes, sir. So,
Thank you, Rimpa, for the
thank you.
support.
Yes, sir. Thank you so much, everyone, for joining this session. Clirnet is really glad to have all these people together. So, with all your permission, shall I close the session for today?
Okay. Thank
Yes,
you.
Rimpa.
Yes, sir.
Thank you,
Thank
sir.
you.
Thank you,
Thank
Rimpa.
you, sir. Yes, sir. Thank you so much, sir.
Thank you.